Thank you. All right.
It's not a bill.
Thanks for putting up with the Keystone personnel approach to this. Please proceed.
Thank you, Mr. Chair. And the lesson learned is red button push turns green. You're good. So we're on the first chart, which talks about what mandates, who are mandates, and what does it affect? And just the bottom line is, if you look in the upper right-hand corner, those affected are the direct purchase, which is about 5.7%, EBFIs, which are the employment-based fully insured, which is about 18.5%. That's the baseline. And then you have the state employee health plan folks, which represent about 2.8% of the state, for a total of affected for 27%, or about 775,000 people. So when we talk about mandates, that's actually the number we're talking about in the program. Good, bad, or indifferent, it just is. So when you say significant, is that a significant number? We just have to answer that for ourselves. Okay, with that, we'll go to the next slide. The next slide kind of talks through a process flow chart, and I apologize, I like to look at things from a systemic point of view. So this is the intended process as you go through your through the statutes. You have a mandate concept. We'll hear them all the time. The first step for a mandate, they basically have two speed bumps, if you will. Speed bump number one is a cost-benefit analysis. That is something that whoever has the mandate idea can go down to research, and research has a responsibility to provide information that's requested. They can also come to the committee, and the chairman of this committee can actually write a letter on behalf of the individual and just say, hey, listen, we want you to give them information. But it's to research. It's not even needed step, and it's not the letter's not needed. But if you want to reinforce it, you can, to ask more things. Or if the chair and the committee have more information to request, in addition to what the other person has in the cost-benefit analysis, it can all be included. And that information is then provided back to the proponent of the mandate. Then the next step has to be an action that has to happen. So the proponent has to take an action, and they can do it through one of two ways. Way number one is through a bill submission. The other option is for a proviso. They can do either one. It ends up here. When it leaves that portion, it also has to have a fiscal note, and it's a state employee health plan that puts together that cost estimate based off all the other information provided. We then go to the next step, which is we take action. If it's approved, then it goes into a test track. That's kind of the idea. If it's not approved, then nothing happens and the mandate goes away. But if it goes into the test track, it should only take it down to the findings submitted back to us, and it stops there. That's what the intended portion is, because then once we get the findings, it comes back into us, or it comes back into the mandate person. They decide if they want to continue to pursue. They then submit a bill, and then we take action from that bill. And if it's approved, then the mandate's implemented. If it's not approved, then it's not. All right, good so far? Real quick, and I'm trying to be fast because I know we got a lot going on. Yes, ma'am. Oh, I'm sorry, Mr. Chair.
Representative Bishop. Okay.
Okay. If they're hard, ma'am, then please ask somebody.
And we may have more, so keep track of them. Please proceed, Representative.
Okay, then you go to the next one, which is the test track itself. So the test track is done with the state employee health plan, which has about approximately 80,000 employees. It's this self-insured plan. But the bottom line as it goes through here, the benefit is identified. Then goes out and it's emailed out to the members. In these programs, the design by statute says it's a minimum of 1 year, and then that information is then provided back to the House or the legislative leadership, and that either being the Senate or the Speaker of the Senate President or the Speaker of the House. And then they decide, and now this is just the state employee health plan, then there's a decision made of whether we continue that benefit in the state employment health plan or not, regardless of the other stuff. So there's still a discussion that has to happen. Even if we decided it's not continued, sometimes the state employment health plan folks can make the decision to continue on and pay it internally and go through that process. So there's many different options when you spin in there, but that, by the way I understand it and going through with research, is how the test track is supposed to run. Again, it's a minimum of 1 year. It doesn't say there's an end, but they're supposed to in the bill say there's an end date. Lost my slide. Okay, and then the last slide there is just basically going back to what the first slide was, which said, or second slide, which said, here's the process that we want. Really, the design for us, as we're seeing bills in here, the original design was the two speed bumps. Number one is the cost-benefit analysis. The second speed bump being the test track. all designed to make sure we know from a standpoint of what we want, what we're getting when we're going through a mandate and maybe implementing one. And it was done based off of things that had happened in the 70s, some experiences where there was a lot of mandates coming in, and then this was designed to kind of just slow it down just enough that we would make sure we're doing the right things as we go along and we're not surprised. With that, Mr. Chair, hard questions to Representative Proctor, please.
So thank you. And the Vice Chair and I had just discussed how do we kind of get our arms around what had been presented in the process. And he had worked with, I believe, the revisor and a few others just to vet that we had it straight here. But we'll go through that in more detail. We just wanted to kind of raise some of the things to think about as we have the chance to apply it to the potential mandates in the next couple of hearings. Does that make some sense? So we will be back to this and go through it in a little more detail. And thank you all for your attention to that. Thank you.
Thank you, Mr. Chair.
With that, we'll move on to our first bill, which is House Bill 2110. And I would ask for an overview from the revisor's office.
Thank you, Mr. Chairman. House Bill 2110 would require the state health care benefits program to implement coverage for the diagnosis and prescribed treatment of pediatric acute onset neuropsychiatric syndrome, or PANS, and pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, PANDAS, beginning in plan year 2022. Pursuant to KSA 40-2249, or the test track that Vice Chair just kind of went over, on or before March 1st, 2023, the Kansas State Employees Healthcare Commission shall submit a report regarding the mandated coverage for PANS and PANDAS to the President of the Senate and the Speaker of the House of Representatives that was provided by the health plan during plan year 2022. The report shall contain the impact that the mandated coverage had on the state healthcare benefits program, data on the utilization of coverage for PANS and PANDAS, and the cost of such coverage, and a recommendation whether such coverage should continue for the state healthcare benefits program or whether additional data is required. At the next legislative session following receipt of the report, the legislature may consider whether or not to require PANS and PANDAS coverage be mandated for other health insurance plans on or after July 1 of 2024. The bill becomes effective upon publication in the statute book, and I can stand for any questions.
Thank you. Committee questions for the revisor? Seeing none, thank you for the overview. I think we will move. I haven't reviewed the fiscal note. I think we may come back to that if that is relevant. I'll wait for a text from research on that, but I think we'll move into our first proponent, who I know needs to be at another meeting, Dr. Epley.
Can you hear me okay? Okay. Thank you, Chairman Johnson, Vice Chair Croft, Ranking Minority Member Neighbor, and members of the House Insurance and Pensions Committee for this opportunity to address you today in support of House Bill 2110 on this very important topic on the need for coverage of PANS or PANDAS. I wanted to have a visual aid with me today, but I guess those really aren't allowed. I wanted to have a PANDA on one of my hands and maybe a PAN in the other, but Chairman Johnson said that would not be allowed. So you'll just have to, use your creative imagination. I love to say this rapidly. We can say it 3 times: pediatric acute neuropsychiatric syndrome, or that is related to associated with streptococcal infections, which is what PANDAS is. So we have PANS and PANDAS, which are very, very similar in nature, but PANDAS is a subset of PANS, which boils down to post-streptococcal autoimmune type infections. So as a physician, I would have to say that this is certainly a newer diagnosis, and that's all relative to, I guess, how long you practice medicine. Having practiced for about 41 years, I would say to me it's relatively new because it's only about 15 years old and only been known a little bit about it in the last 10 years. And so as we arrive at that, we understand that there are a wide array of treatments for this, and we've tried all sorts of things. And we've centered around treatments as they relate to corticosteroids, and which are more traditional in nature, also some counseling. But then the big treatment is immune globulin, as you'll read and hear from some of our proponent testimony. Being very aware of the test track request. That's really what this bill is about, and that's what's codified, is request a test track with either the State Health Employees Plan or with advice and guidance from the committee on another population that may be appropriate to try to come to a determination of the costs involved with this. The costs of immune globulin are very high. I can remember the days when immune globulin cost under $100 for the treatment of hepatitis B in the 1980s and the early 1990s. Well, that's changed a little bit. And with the onset, basically, of AIDS and HIV syndrome, immune globulin was utilized a lot at that time 30 years ago, and the cost skyrocketed. It was also used extensively in the military for military veterans that became ill during some of the Gulf Storm and other deployments. So having said that, make no mistake about it, PANS and PANDAS is a very real definitive diagnosis. It's bona fide. It has an ICD-10 code to it that you'll hear about. And this bill originated in House Health 2 years ago. It's had 2 hearings, and as a result of our interim hearing last October, we decided to send this to you all for your consideration because it has such an insurance impact. And we think it's important that you give this due consideration because of the cost that it's involved. And so you'll hear from a wide array of not only proponents to help answer a lot, I hope, of your questions about what this is, but also about the costs and about the needs for this population going forward. So basically, we're going to be requesting referral for a test track to obtain more data on the costs as it applies to the state population. And then at some point, perhaps we can move it out as a mandate in the state. So I would like to say I'd stand by for questions. I guess I could take a few questions now quickly, but I don't want to keep you from your other proponents and the other folks, and I need to be in tax. So is there any quick questions, Chairman, that I should answer for you?
Thank you, Representative. I'd have one. We will review the fiscal note next, and if you had anything to set us up with that or what had been done in past sessions around this, just to kind of bring us to where we are. And then the other thing that I would ask, while I know we're asking for the test track, what information do we have on the impact study for cost and both fiscal and social?
So on the fiscal note, I have not been privy to the fiscal note. I don't know when that came out, but I was looking for it, so I can't respond to that today. I think that certainly is part of the process as well outlined by Representative Croft.
Okay, and anything from, I know you've been working on this for more than a year, and what, anything we need to pick up on from past years that had been accomplished or discussed?
Well, and you'll hear from the other proponents, but it's a somewhat rare disorder. It's extremely impactful in those individuals and families that deal with it. It's very abrupt in onset, as you'll hear from the proponents, and it's without prediction. You cannot tell. It doesn't respect any socioeconomic background. It can affect families of all backgrounds. And when you see and hear about some of the cases, you'll understand the impact and the importance of trying to provide treatment going forward. I hope that's helpful.
Thank you. Other questions? Representative Neighbor.
This is short and quick. What have you seen in the rise of cases that are starting to happen since this is, what, a 10, 15-year period? So what is the percentage of, how much is it?
It's a rare disorder, Representative, and I will say, to give it an absolute figure, I would look to some of the other proponents to give you that information. I believe that we are diagnosing it more frequently now, kind of like some of the spectral disorders, because we have a broader net to cast, and we're looking for it now, whereas this probably has existed long before I was a physician, but we called it something else. We called it, a lot of these symptoms present as mental health symptoms, and so they're confusing and they're diagnosed as a spectral disorder or attention deficit disorder or other mental health disorders. And now they're falling under the PANS diagnosis, which is now more bona fide, and there's a more definitive treatment. And when you see the cause and effect of the treatments, it's quite remarkable. I don't know if that helps you, but a lot of that data will be forthcoming from the other proponents today.
Thank you, and thank you, Mr. Chairman.
Thank you. We'll take one more question for the representative, and that's from Representative Collins.
Thank you, Mr. Chair, and thank you, Dr. Eppley, for being here. And I've been in on a couple of the hearings when I was on Health and Human Services about this, and something I remember then, and I believe I remember, this is correct, that as far as symptoms, it looks a lot like autism. Is that correct?
Yes, sir, and that's what I was referring to. Many others, autism, spectral disorder, other psychiatric disorders can be very confusing with this disease.
All right, thank you. Thank you, Mr. Chair.
Thank you, Representative.
Thank you, Mr. Chair, and thank you for your consideration today, committee.
So at this point, we'll take a step back and ask for our research to go over the fiscal note.
Thank you, Mr. Chairman, committee members. Just looking at the fiscal note, a reminder, the state employee health plan runs on a calendar year basis. So the fiscal note is going to speak in kind of two halves. It's going to speak to cost in both fiscal year 2022 and fiscal year 2023. And the fiscal note indicates that the Department of Administration, which is responsible and contains the state employee health plan as a result of a recent executive reorganization order, the department estimates that cost to the state employee health plan would increase by $242,236 from special revenue funds in fiscal year 2022. And this assumes that there would be a first year cost increase of $484,471. But noting, because this is a January 1st, 2022 start date, only half of those costs, which is why we have $242,236 would be applied to fiscal year 2022. And then for fiscal year 2023, the department sees an overall increase for cost and usage of 5.50%. So they would add an additional $26,646 to factor into that amount if you were looking across the two fiscal years. The insurance department indicated that there would not be a fiscal effect on its operations. And I would note that there is not information provided from the Department of Administration regarding incident rate or a suggested number of members or a per member per month cost. That information or treatments that would be available or considered by the plan. So there's not information on how they reached that estimate.
Thank you. Committee questions? Seeing none, thank you for the review. We'll move to our next proponent, and for our proponents, in the interest of time, if we could target 5 minutes, and I'll cut you off at 6 minutes, and that if our rest of our conferees have 6 minutes, it will take us an hour, and we'll complete our time. But I appreciate everyone being here and would like to welcome Dr. Roger Kobayashi, and if you can correct my pronunciation, thanks for joining us from the UCLA School of Medicine.
Thank you. So I apologize for the fact that I am not well tanned. I'm from Hawaii, but now that I'm in Nebraska, unfortunately, you can see how I look.
185. The agency budgeted $10.6 million for 360 contracted beds for adult male inmates at the Saguaro Correctional Facility in Eloy, Arizona, and 45 contracted beds for female inmates at County Jail.
Was that an interruption?
That was an interruption. Our technology department apologizes to you, Doctor. So please
Sounds like our
begin
football
again.
team in Nebraska. Okay, if we have 6 minutes, I will forego my slides. The slides are for reference.
Okay.
And so there's several points, and what I'll do is I'll answer some of the questions that the people asked. I think there are 4 points that I want to make. The first is that PANS is an inflammation of the brain. And so it is different from the other diseases that you see in childhood. And the reason why IVIG is used is that it is an immunomodulator that suppresses or corrects the inflammation, and that's why it may be. The second point is that IVIG is very effective in the treatment of recalcitrant PANS. So what this means is that after they have failed the usual therapy, such as antibiotics, anti-inflammatory steroids, psychiatric medications, and behavioral therapies, this is when IVIG is used, and obviously it's because it's expensive. The third part is, of course, it's expensive, and the fourth part that I would like to emphasize is that IVIG should be used only if the criteria are met. and that in addition, you have moderate to severe refractory disease. And then finally, before you use IVIG, you must document. And we have means of doing this to prove that this is a severe disease and they fit the criteria for PANS. And then secondly, when you give IVIG, these symptoms improve. Let me give a little background about myself. I've been in medicine for about 43 years. I was among the early when we started using gamma globulin for primary immune deficiency. So this has been over 40 years. In addition, I treat about 300 patients with primary immune deficiency with gamma globulin over an 11-state area. And finally, I have evaluated about 140 PANS patients. And so in my slides and in my handout, it says that they must fit this criteria, and I beg to correct Dr. Epley. This is a distinct disease which has been described by the National Institutes of Health and agreed by an expert panel. And so the criteria are on the left, if you can see, either sudden onset of tics or OCD and eating disorders. And on the right side of the slide, if you're looking at the handout, the right side says that they have to have 2 out of the 7. And the thing is that this has an enormous impact on the family. These children have bizarre behavior. The reason is usually there's an infectious trigger. So they get some kind of infection, whether it's strep or whether it's a virus. It causes the body to misfire and cause inflammatory disease in the brain. And again, because we don't have time, it can show what happens if you have inflammation in the basal ganglion, which is the part that has automatic movement, behavior, motion, and emotional behavior. So I think this is critical. If you have inflammation of this area, you have a sudden onset of this bizarre behavior, and then the problem is proper diagnosis, proper treatment. These patients oftentimes get put on psychiatric medicines where it's not helpful, and these patients, oftentimes the family will suffer for months, if not years, and I've seen some that have gone on for over 10 years. I was not excited about this disease because I started off as a molecular immunologist. My interest is primary immune deficiency antibody. And when the doctor from Chicago sent me 2 kids to treat with globulin, I said, what kind of nonsense is this? This is a bunch of baloney. However, I'd point out, and we don't have time, but there are now many institutions, including Harvard, Yale, Columbia, Johns Hopkins, UCLA, Stanford. These are the best medical schools in the country. They all believe that this disease exists. They're all doing animal models, which are impressive. And this is what convinced me. 2 things convinced me. Number one, the laboratory data, absolutely overwhelming. And the second thing is when I saw these patients and the families, I said, I am a physician, I have to help. The same thing, I was at UCLA when AIDS broke on, and I said, what the hell? I mean, these guys got themselves into trouble. Why should we bother with this? And then I started seeing these patients, and then I started saying, you are a physician, you don't make value judgments, you take care of these patients. So unfortunately, we don't have the time, so I'll go over very quickly the cost to treat a 40-kilogram person. This is about an 8 to 10-year-old kid, will be anywhere from $5,000 to $10,000 a year, depending on the dosage used. And again, unfortunately, we don't have time to show you the slides, but it also depends on the contracting company, where you infuse the product, what brand of gamma globulin you use, and finally, what kind of insurance the patient has. And the thing is that you know that the insurance, the hospitals or the clinics or the home infusion companies may charge anywhere from 5 to 10 times more. But the reasonable cost for a 40-kilogram person, in other words, an 8 to 10-year-old child, would be about $5,000 to $10,000 per treatment. And again, we don't have time to go over it, but there are 4 studies, including ours. Our study is published, but the gist of it is about 90% of these kids will respond, and this is when they failed everything else. And if you correctly select these patients, they respond, and that was the surprising thing to me. When I saw these kids running, screaming, hiding underneath the table and acting like zombies, I said, there is no way I can help these kids. This is they should be seeing the psychiatrist. And then when we started treating, the parents would call up unsolicited, and they said, my kid is normal. I had a patient first from Minneapolis and one from Kansas City. And they called and they said, my kid is normal. And I said, I don't believe you. And then when they came up, the kid is sitting there answering questions, behaving like the way they're supposed to. So I want to finish up with one point. Number one, these are kids that typically are normal. They get some kind of an infection or a hit, and then all of a sudden they start behaving bizarrely. And this distinguishes it from other of the psychiatric problems, which are more slow onset in coming. The second thing is that this is very expensive to treat. And so because insurance companies don't cover it, it puts an enormous burden on the family. And then finally, I would argue that from a scientific standpoint, there are diseases like this. The neurologists are looking at them more carefully. They're finally beginning to employ immunology. And when you use IVIG in correctly selected patients, the response rate, as has been shown by the consortium, is about 90%. I'm open to any questions.
Thank you. I believe we'll complete our proponent testimony, and then I'll open it to questions for all of our proponents. So next we would have Dr. Richardson with the University of Kansas Medical Center.
Hello, thank you for having us today. I am going to change my presentation a little bit just because Dr. Kobayashi did address some of it. Am I able to share content?
I believe that you can.
Okay, I'm going to share my screen here. And can you all see this? Can you see the slides?
Yes, we can.
Okay, great. Thank you. So here are the diagnostic criteria Dr. Kobayashi mentioned. One of the things to note is there is an abrupt change. So this typically comes on pretty suddenly, assuming that you catch the first episode and you have obsessive compulsive disorder or severely restricted food intake. This can look like anorexia, or it can also look like fear of contamination for food. And you have the other symptoms listed below, which are typically severe anxiety, emotional problems, developmental regression. You can see changes in motor function too, handwriting changes. Some of those things are more documentable, motor tics or involuntary movements. And this is not explained better by something else. So here's an estimate from the National Institute of Mental Health that 1 in 200 children per year is thought to get PANS, pandas of course being a subset of that. And the average age of diagnosis is 3 to 13 years old. Now, that being said, a lot of these kids are misdiagnosed with psychiatric problems. And I'm sorry, I should have introduced myself. I'm a general psychiatrist practicing in Wichita. So a lot of these kids probably have been through my system and seen me also, unfortunately. Now, about 70% of these kids have a family history of autoimmune illness. So that's a clue there that there's something more going on. There's really no age requirement with PANS, though it's more common in childhood, of course. Now, most of the kids have most of the symptoms, but to varying degrees. So in a mild case, it may be that they can still attend school, but in a severe case, the symptoms really may take up to 80 to 100% of their waking day, and it may be lethal. And that could either be because of the extreme mood changes leading to suicidality, or also the extreme food restriction leading to starvation. Here's some examples for you of things that can occur. The pictures are drawn by the same child. It was a 10-year-old child, and the picture on the left was drawn in the middle of a flare, a panda's flare, and the right was after treatment with IVIG. So you can see the dramatic change in motor function and improvement with this treatment that Dr. Kobayashi was referencing. Once again, there's some handwriting changes. The left was pre-morbid prior to developing PANS or PANDAS, and the right was during the flare, the same child. We've already kind of discussed some of this and the misdirected immune response that attacks the brain. The part of the brain that's affected is called the basal ganglia. And it has to do with reward processing, cognition, motor control, emotions. And so you can start to see how all of these things are connected. So one of the biggest things to keep in mind is that many kids have a relapsing remitting course, meaning that symptoms come and go. So it may be that they get better with treatment and it may come back later in life. And the triggers are not always the same for that. So the problem is in between these episodes, they may not heal clear back to their baseline. And so with every infection, if they're not getting proper treatment, they can have a little more damage and a little more damage. And this really increases over time to become a chronic problem. So timely diagnosis and appropriate treatment are very important. Here's some of the doctors and universities who established the PANS Consortium and the diagnostic guidelines back in 2013. Those diagnostic guidelines were published in the Journal of Child and Adolescent Psychopharmacology in 2017. So there's really a three-pronged approach. One, there's antimicrobial treatment. If this is determined to be some sort of infection, then you would treat it with antibiotics, but things like viruses or metabolic problems can trigger this also. So that's an important part. The next prong is the immunomodulatory treatment. So that's where we look at things like IVIG and steroids that he's been talking about, anti-inflammatories like ibuprofen even. And then the third prong of treatment is my scope of practice, where we have supportive treatment, psychiatric medications if needed, and therapy. So keep in mind, only the most severe cases really eventually get referred to IVIG. And I think we've discussed why timely diagnosis and appropriate treatment are so important. So it leads to a better recovery rate, but also for the person, less cumulative symptoms over time. The National Institute of Mental Health actually estimates that if we treated this appropriately and caught all of the cases, we could prevent 25 to 30% of childhood mental illness. And even if that seems like an overestimate, you know, if we could prevent half of that, that's still very, very significant. The reason I'm so passionate about this is because my daughter Brielle actually developed PANS. It was very suddenly a textbook case in October 2019. She was 5 and had just started kindergarten, and September she actually got Student of the Month, and then she came home one day in October and had the worst case of OCD that I've ever seen as a psychiatrist. She believed that she had accidentally swallowed a large amount of hair or worms, and she started checking her mouth consistently. I mean, that was about all she was doing through the day. She started refusing to eat over the course of the next 2 days because she felt all of our food was contaminated and there was nothing we could get her to do. She had very significant behavior changes. She was very emotional. At one point, she became very aggressive with myself, with the other kids. She regressed. She had repetitive speech, very baby-like, which was, you know, none of this was like her. And she developed a motor tic where she was smacking her lips constantly. I don't know if you can see this video here, but this is just an example of her in the hospital. I think you can see the lip smacking tic that I mentioned, her repetitive and regressed speech. And then at one point in the video, I try to give her a sip of water, and you can see that her reaction, and this was because she believed it was contaminated and would kill her. So all of, all of that is, you know, not her baseline. So on the symptoms rating scale, there's 23 symptoms. She had 19 of these to a moderate severe degree. And like I mentioned, they started on a Wednesday in October. Despite that, we had a lot of difficulty getting an accurate diagnosis. She was misdiagnosed by multiple doctors, however, and even myself being a psychiatrist, I was not familiar I was undereducated about this diagnosis, as I think many of us are, but I knew enough to know it wasn't psychiatric. So I continued to push for workup and treatment. And we eventually got a fairly quick diagnosis by most people's standards. And we were able to treat with anti-inflammatories. So she had a lot of ibuprofen, a course of oral steroids. And one of our biggest treatments has really been significant dietary changes. So she is now on a gluten-free diet, and we try to minimize sugar. And this was all set off, we believe, by an immune response to just a common, basically cold virus, rhinovirus, enterovirus was what she tested positive for. It took about 5 months to fully recover, but of course she never needed that IVIG because we were able to catch it so early. So I hope that we can, find a way to get similar outcomes for others in our state, and regardless of the severity.
Thank you, Dr.
I'd be happy
Richardson.
to answer any questions. Yeah, thank you.
So we will, and I apologize to both doctors for the time and a lack of a commensurate introduction for the credentials you have. It was very impressive to look at that history, so thank you. We're also fortunate to have Shannon Wright with us, I believe, here in the room. So welcome to committee.
Just thank you for the opportunity today to testify in front of your committee. My name is Shannon Wright. I'm a master's level social worker. Yes? What's that? Oh, okay, thank you. I'm a master's level social worker in the state of Kansas. I've been practicing social work for the last 28 years, primarily with children and families. I am also a mother of a recovered PANS patient. Her sudden onset at age 9 was completely debilitating. She is now 18 years old. I credit her recovery to access to IVIG as part of her treatment. She's graduating from high school this year, being a model student, working part-time and planning on attending college and pursuing a degree in the medical field. This illness is not only devastating for children, but also affects the family, school systems, and the community. At her worst, she couldn't maintain in the general education classroom at all. She had to be in her own office with 2 paras because she was so violent and aggressive and a run risk. Complete change from the child they saw before her onset on September 13th, 2011. Caring for someone with PANS comes with unique challenges and is often scary and unpredictable. This can result in high caregiver burnout, stressing the school systems as well, who have difficulty coping with the sudden changes and extreme behaviors. The pilot program proposed will allow children and families to access medical treatments that would appropriately address the underlying causes of the behaviors that children are experiencing. I think there are several factors to consider as we move forward. One, offering coverage to a broad enough population in order to catch enough cases to give the state of Kansas enough data in order to complete a cost-benefit analysis. Different groups that could be considered are state workers, school district employees, and those employed by Kansas universities and medical centers. 2, making sure children identified that take place in the pilot are truly truly children with PANS diagnosis. It may be considered who is making the diagnosis, such as an immunologist, a rheumatologist, neurologist, or other PANDAS knowledgeable providers. Specifically naming treatments that will be covered when treating PANDA and PANS. Antibiotics, steroids, ibuprofen, and a variety of psychiatric medications are already generally covered by insurance. IVIG is the most expensive, and in our experience, the treatment that made the most impact is routinely denied by insurance. Thank you again for your interest and your time in considering our bill.
Thank you. Thank you for joining the committee. With that, committee, are there questions for our conferees? Representative Collins.
Okay, I was out of the room for a bit, so if I missed this, I apologize. But is there ever an end to this? You know, it starts in childhood. Does when a person with this condition goes into adulthood, does it carry on with them then?
Yeah, I think I can speak. This is Dr. Kobayashi. I can speak to that. We've seen about 140 patients, as I've said, over a number of years, and I apologize for my voice. I've been talking about COVID, and I'm sick and tired of COVID. But having said that, I would say about 80% of these children are now normal off all medicine. And if you look at the IVIG studies, both from the NIH, there's a big Italian study now looking at 34 patients where they did one or several treatments. All of their patients got better. I think there were about 20% who had continual symptoms, but not as severe. The idea is that most of these children, what happened, I don't want to get into the, I'm a molecular immunologist and nothing is more boring than a lab rat. But suffice to say that in young children, the immune system is not fully developed, so they can make a mistake and they generate autoinflammation against that part of the brain that the doctor from Kansas addressed. And it seems as though as they get older, this seems to correct itself. So the disease almost burns itself out in the vast majority of these children. And so many of them, if they're diagnosed early, they're treated aggressively and early, you can abort the disease. And we have a number of kids who are perfectly fine now. And I defer to my colleague in Kansas because you have experience. I'm a physician that doesn't have, kids with pandas.
I would
Thank you.
agree with you, Dr. Kobayashi. Yeah, I think that we're probably seeing a lot of children with these who have chronic mental illness who were probably should have been diagnosed years ago, and we could have prevented a lot of the hospitalizations and a lot of the really heavy duty med trials that still are not working to this day.
All right, thank you, doctors, and thank you, Mr. Chair.
And we have time for just a couple of questions. Our next is from Representative Berquist.
Thank you, Mr. Chair. Just a question about one person, I can't remember which person mentioned that numbers of incidences could cause more severe reaction, or not reaction, but damage. Are the damages like sclera on the nerves, on the nerve endings of the brain, is there permanent damage so far been recorded? Is it something that permanently damages the nerve endings?
We had Dr. Soweto from the NIH. That was an important question. I think there are a couple of considerations. Number one, the earlier you diagnose the patients and the quicker you treat them aggressively and appropriately, the better the outcome. The harder ones to take care of are the ones that have had it for quite a while. And in fact, we have been funded for an international study using IVIG for 2 years. And the reason is that we want to see, and we excluded anybody whose symptoms started 6 months or before. And the worry was because if you catch them late, you may not be able to improve the situation. And I'm making a quantum leap, but bear with me, because I see mostly patients with severe lung disease. And these are individuals, a lot of times, who have immunodeficiency. In other words, their immune system is defective, and so they get a lot of pneumonias, lung inflammation. And the problem is when you damage the lung, you cannot repair it in older individuals. And so the worry in this disease is if you let it go a long time without proper diagnosis, as my colleague from Kansas has said, they may have permanent problems. So it may be appropriate to diagnose this early and treat it appropriately. And I was an economics major, by the way, when nobody knew what economics was 50 years ago. But I do know that if you do cost analysis, having these kids in the hospital, having them followed for a long time, will cost you more. We made the same argument treating primary immune deficiency.
Thank you. Is there another question from the body? Seeing none, to our conferees, a sincere thank you. And while it's possible to get boring in any detailed topic, I think we all enjoyed having the chance to learn from our self-proclaimed lab rat and would welcome a chance to learn more. So thank you for joining us. Is there anyone else wishing to appear as a proponent for 2110? Seeing none, I do have a neutral listed, Mr. Brad Smoot on behalf of Blue Cross. Welcome to committee.
Thank you, Mr. Chairman, members of the committee. Can you hear me all right, everyone? Hope so. I am Brad Smoot. I'm with Blue Cross Blue Shield of Kansas. Many of you know our company. We've been around for about 75 years. We serve 930,000 Kansans, your constituents. And we have offices in 11 cities around the state and serve 103 counties. Wyandotte and Johnson County are taken care of by Blue Cross Blue Shield of Kansas City. We're pleased to appear today as a neutral party on this, and I'll try to explain the rationale for why we've elected that position. The first is we commend the authors of the bill for attempting to put this through the state test track. That's part of what the state law requires. KSA 40-2249A, as Representative Croft indicated, requires that to be done before mandates can be considered. I remember Representative Neighbor was involved in part with the amino acid bill to get that done through that same process. And we appreciate the legislature, rather than trying to avoid these, as Representative Croft said, speed bumps, has agreed to try to get the state employees plan to provide a test track or a pilot project, whatever you want to call it, so that we take the state's largest single employer group, figure out what the benefits are, who's affected, how much it might cost, and you also determine at that point, you know, if you're eventually going to impose this on employers and families and individuals who buy health insurance, you'll know what it costs, and you've agreed to pay for it yourself using taxpayer dollars as their representatives. So we applaud them for that effort. Unfortunately, the effort did not include the first speed bump. The test track law was enacted in 1999. The first speed bump was enacted in 1990, and it's the one that requires the supporters and proponents of any mandate to provide you with an impact report that looks at the social benefits. You've heard a lot about that, and the medical benefits of what's being proposed here, and then the financial costs of that involved. If this is being done in other states, if they've got some estimates on the incidence, if they've got estimates, and we've heard some about the potential cost per treatment and so on, that way you would at least know, and your people who devise the fiscal note would at least know what the likelihood and the consequences are for your state budget as you do this one-year test track requirement. And unfortunately, that was not done, and so we would encourage anyone, whether they're bringing this proposed mandate to the committee or some other one, to follow both of the speed bumps so that you have the best possible information available to you. I would note on behalf of Blue Cross that we already cover numerous treatments. I don't want anyone to walk away from here thinking that those treatments for PANS and PANDAS are not already covered in large measure by our insurance company and by others. We cover the antibiotics that have been mentioned, the steroids like prednisone. We cover their autism ABA therapy. We also cover physical and occupational therapy, regular office visits, and other services associated with this condition. They may not be the right ones, as you've heard from these medical experts. I'm just an old country lawyer who went to law school instead of medical school. So I'm going to focus primarily on the legal aspects of it. But I would call your attention to the wording of the bill. The bill on page 1, lines 15 through 16, requires the state employee health care plan to provide coverage for any prescribed treatment. Now, I think the intent here is to go for the IVIG treatment that's been discussed, but nothing in the bill limits it to that. It's for any treatment that might come along next year, might be out there that some doctor wants to use that may or may not be road tested and be perceived as appropriate. It may be an off-label use of some other medication. So you may want to take a close look at that aspect of what is in the bill. Blue Cross also covers IVIG for other disorders. So it's not like we have anything against this particular product. We do provide it and pay for it for a variety of other conditions. One issue of interest that you'll want to think about on this and all the other mandates that you may come across is that this condition and this treatment for this condition are not part of the Affordable Care Act requirements. We have what are known as the essential health benefits that the state employees health care plan follows, and all the most of the insurance products that are out there are ACA compliant. This benefit is beyond that, and being beyond the ACA requirement as required essential health benefits means that should you attempt to apply this outside of the state employees health care plan, you would have to pay for, as a state, using the taxpayer dollars, for the cost of that under the federal law. We may see a lot of changes in the next year or two as to what federal law is going to require, but that's the current status. That's kind of the reasons why we appear today as neutral. We see legal issues with the bill draft. We see legal issues and practical issues. We wanted to make sure that you understood that we pay for a lot of services. We consider, as do most insurance companies, that this particular treatment for PANS and PANDAS is experimental, investigational, needs more investigation and research. When it becomes widely accepted, I guess, the insurance industry will add it to its list, or the ACA will add it to its list of required. But you are certainly free as a legislature to add it to the benefit levels and benefit requirements of the state employees health care plan. And so that, again, is why we appear neutral. We're not taking a position on the merits of the medicine or the studies that have been done, other than to say that you can do what you want to do with the state employees health care plan. You've got an estimate on what it might cost. You know that it is experimental, at least in our view, and you can go from there. With that, Mr. Chairman, I'm happy to respond to questions as best I can.
Thank you. We have one question from Representative Neighbor.
Thank you, Mr. Smoot, for being here today. It's always nice to see you.
Nice to see you.
In your testimony, you said you provided IVIG treatment to several different areas. But the thing I'm not hearing is you do not provide it for PANS and PANDAS. Is that correct?
That's correct. And that's because the people that make the decisions about what we believe to be medically appropriate treatment have not yet decided that treatment for PANS and PANDAS should involve this particular treatment. We do provide it for other conditions. Please don't ask me which ones, but
That was my next question.
I was afraid of that.
A second, if I may. I think it was brought up that this has actually been studied for quite a while, known for 10, 15 years. How many things on the ACA market are new and have found treatments? And medicine is relatively new in itself. I mean, the wearing of gloves, having no food in the room, those kinds of things have happened through time as safety measures. So how long is it before you believe, with the studies that have been done and accepted in this area, do you think how many studies need to be done and for how long?
Well, I can't give you a number on how many studies. I can tell you that we look at it every year along with other benefit levels. And when our folks determine that we think it's should be included as a benefit, we'll do it. If you decide we should include it as a benefit, we'll do it. But until then, our folks have not determined that this is something that you as premium payers ought to have to pay for. And I might mention to you, just for those of you who are believers in or know folks that buy high deductible health plans, a lot of these conditions that if we mandate coverage, they will count toward your deductible. You'll still be paying for those out of your own pocket. It doesn't necessarily automatically mean in all cases that the insurance company will be paying for that cost of treatment.
Thank you. And I'll heed the floor for a minute.
Representative Proctor.
Thank you, Mr. Chairman. This may be an unfair question to ask you, but I'm going to ask you anyways. Is this treatment covered under CanCare?
That's a great question. We do not participate in CanCare. I can certainly ask around, and your staff may be able to find it a lot faster than I can. I'm not sure that it does. I believe I've had some information that suggests it doesn't, but I'd prefer that you ask your experts and have them tell you.
And Mr. Chairman, if I could follow up, my next question, I'm just really trying to wrap my head around this, is if we were to pass this bill and this were to become law, how does modifying the state employee health care plan in any way impact that, CanCare coverage or coverage by private insurance? Is it just that it potentially creates pressure or creates a precedent? Or, I guess I'm trying to understand why it's of concern to a private health care insurer.
Good questions. We care about it and monitor the situation, and our opinion on it has some relevance because we, along with Aetna, are the suppliers of health coverage to the self-insured state employees plan. You pay for the state employees plan. As a self-insured, we administer the claims. And so we monitor this, gather data as you request, and so we have it. So that's the answer to why we're interested in it initially. The second answer is that, and as this bill contemplates, wisely so, and again, I want to be complimentary of that, that once you get the report back in March of 2023, you can make a decision whether you want to apply it to CanCare or you want to apply it to the private sector. And as Representative Croft pointed out, that's a limited number of people who are not exempt for other reasons, like their ERISA groups. But to those that you can affect, you could apply this as a mandate and add those benefits along with those costs to the premium burden of the Kansans who would be subject to the mandate.
Our last short question from Representative Neighbor.
I promised it would be short. Who sits on your review board that decides what is covered and not covered? With this being a newer diagnosis of which even psychiatrists or psychologists have problems with, I would just like to know who serves on that board and the experience.
I don't have that or their bios at my fingertips, but I'm happy to get that information. And each carrier will have their own, and they'll read the literature that's out there, and they'll look at the universities and the medical schools that are studying this and try to keep up as best they can with this and every other treatment that comes along.
Thank you very much.
You're welcome.
Thank you, Mr. Chairman.
Thank you for your testimony. Is there anyone else wishing to appear neutral? Is there anyone wishing to appear as an opponent? Or anyone else at all on House Bill 2110? Seeing none, again, thank you to our conferees, and we will close the hearing. With that, committee will turn directly to House Bill 2129. Thank you for the patience of those waiting to testify on this bill. It is good to see each of you here. We will begin with an overview from the Revisor's Office.
Thank you, Mr. Chairman. House Bill 2129 this will sound probably pretty similar to the last bill we heard. This provides that the state healthcare benefits program would be required to implement coverage for tobacco cessation benefits beginning with plan year 2022. Tobacco cessation benefits provided under the state healthcare benefits program would include coverage for at least 4 90-day medication-supported tobacco cessation treatment attempts per year, individual or group counseling, including telephonic counseling for tobacco cessation provided by any provider with education and counseling within the provider's scope of practice, combination pharmacotherapy for tobacco cessation, such tobacco cessation benefits provided under the state healthcare benefits program shall be provided with no lifetime limit, prior authorization requirement, or cost sharing requirements. And then, as in the other bill, on or before March 1, 2023, the Kansas State Employees Healthcare Commission is required to report regarding the tobacco cessation coverage under this section in the manner containing the information as required by 40-2249A. That's the test track provision we discussed earlier. That report has to be submitted to the President of the Senate, the Speaker of the House of Representatives, and then also it has to be delivered under this bill to the Senate Standing Committee on Financial Institutions and Insurance, or any successor committee, and the House Representative Standing Committee on Insurance and Pensions, or any successor committee. The bill becomes effective upon publication of the statute book, begin with the coverage commencing in plan year 2022. And I can stand for any questions.
Thank you. Committee questions? David, do you have any information on whether we have crossed the first speed bump with this already, and made the request for the cost benefit?
I do not know that, Mr. Chairman. There may be others that can speak to that.
Thank you. Seeing no other questions, thank you for the overview, and we would move to research with the fiscal note, please.
Thank you, Mr. Chairman, committee members. The prior fiscal note prepared us for, again, looking at a fiscal note prepared by the Department of Administration, and that is that we will be looking at a plan year 2022 cost. So that will be over 2 fiscal years for part of fiscal year 2022 and for the beginning part of fiscal year 2023. The state employee health plan, the estimate would be a first year annual cost increase of $71,000, but only half of that would apply in the first fiscal year. There was a prior fiscal note provided. This is the corrected fiscal note. It should say on the first page under the date corrected. And so this is just simply updating the cost estimate that they provided. And for the cost, it would increase to $75,205 in fiscal year 2023. For this estimate, $64,355 would be for physician fees and $10,850 would be for drug costs.
Thank you. Committee questions? Seeing none, we will move to our first proponent. And if we could have Tammy Gurley-Calvez, and please correct me on that, doctor, from the University of Kansas.
Thank you very much. I appreciate the opportunity to speak today. And so I'm an associate professor and PhD program director, but my views do not necessarily represent those of my employer, KU Medical Center. So I'm speaking to you today as an expert in health economics. So hopefully maybe some of the study can answer some of the questions on the financial side. Obviously, smoking has a tremendous effect on people and on the economy, and the speakers who present after me will have more to say on that front. I'm going to really just focus on the estimates that we put together. So our question was simple. Under ACA mandated coverage, 2 quit attempts are covered, and so our question was, does it make economic sense to expand that benefit to 4 quit attempts per year with counseling? And when I say quit attempts, I mean 90 days of prescription and 4 counseling sessions. Of course, not all of that will be taken up by every patient, but we've included the cost for all of that in our estimates. The cost estimates are specific to private insurance plans or employer insurance plans, and not public insurance plans. So we looked at the cost of actual prescription coverage patterns, so not wanting to make any assumptions here about what will be used, letting the doctors and the patients make the decision about what treatment that they will have for their smoking cessation. And we looked at actual costs. These are in 2017 dollars, so we could inflation adjust these and the numbers would be a little bit different, but inflation hasn't been quite as much of an issue as it used to be in the early days of my career. And then we include counseling sessions at $30 per session. That's probably a high rate. That's an intensive session. The Medicare reimbursement rate for an intensive session of greater than 10 minutes is $27. So we tried to err on the side of being high there. In terms of medical costs, this is what do you save when someone quits smoking? And so we look specifically at the savings from current smokers to former smokers. So not the difference between if you never smoked, because the medical savings is definitely less if you have smoked before. We looked at it specifically by age and by female and male. And we looked at only people who are less than age 65, so not Medicare eligible. We allowed for the fact that some people quit on their own, 5% of people, and the rates of quitting are higher when you have treatment. And then we allowed for the fact that about 4.4% of people who successfully quit eventually start smoking again. So to the results. So when you expand coverage, as you might imagine, you have higher costs in the early years. So in years 1 through 3, costs are higher because you're providing additional services. And so in year 1, cost is higher by cost on a per smoker basis of coverage is $58 versus 2 quit attempts, which is $32. So we're really looking at the difference between those two numbers. But starting in year 4, you see a positive annual return. And so you might wonder, well, what about the cumulative effects over time? Is it a net positive over time, and when does that start? It starts in year 5, and by year 10, the economic benefits of covering 4 attempts are about double of the economic benefits of covering 2 attempts. And I'll just put some dollars. So if you expand coverage to 10,000 smokers, not all of them will take up treatment, but the cost is calculated on a per smoker basis. The economic benefit net in the economy is about $600,000 over those 10 years. And then we can talk. And I want to mention that we specifically did not include some of the other things that you might get if you cover smoking cessation, which is quality of life improvements and spillover benefits. So if someone's successfully quitting, makes it more likely that their friend or family member will successfully quit. We didn't account for those possible benefits. Thank you very much.
For that overview. And again, committee, we will hold questions for the end of our proponent testimony. Next, we have Rick Kagan, National Association on Mental Illness, Kansas. Welcome to committee. You're still on mute so far.
My apologies, Mr. Chairman and members of the committee. I'm glad you can hear me. Again, I'm Rick Kagan. I'm the director of the Behavioral Health Tobacco Project for NAMI, Kansas, the state organization for the National Alliance on Mental Illness. And I want to thank you for this opportunity and also express appreciation to Representative Epley for his bill introduction. You know, in the last few years, we've seen a growing interest and engagement involving hundreds of primary care and behavioral health care providers in Kansas who receive training to effectively address tobacco use among their clients and patients. And on the first page of our written testimony, which I won't review, you'll find data on the incidence of tobacco use among individuals with mental illnesses and addictions and the serious preventable health consequences, including early death. In Kansas, smoking accounts for annual healthcare costs of $1.12 billion. 70% of excess medical costs can be avoided if we can get smokers to quit before they begin experiencing symptoms. And we can double quit rates by providing effective treatment. So House Bill 2129 is based on changes to benefits in CanCare, which the legislature adopted in 2018. CanCare includes both counseling and pharmacy benefits without lifetime limits, prior authorization, or co-payments. And my written testimony on page 2 provides more detail about the CanCare benefits, which we seek to replicate in this bill. The utilization of tobacco benefits in the state employee health plan is extremely low compared to CanCare and compared to private insurance plans. But on an encouraging note, we saw a 12% increase in the utilization of cessation benefits in CanCare through 2019, following the adoption of the 2018 changes. House Bill 2129 would achieve modest increases in tobacco treatment benefits in the state employee health plan to provide for year-round medication-assisted treatment and counseling benefits, and lifting the limit on quit attempts per year is a simple way to improve outcomes. We provided you with a copy of the return on investment study, which Dr. Gurley Calvez has just reviewed, and as well as an infographic which summarizes some of the key economic impacts of the proposed changes. We urge you to adopt House Bill 2129 to establish a comprehensive and barrier-free tobacco cessation program for state employees. On the third page of our written testimony, you'll find a list of 14 Kansas organizations who've endorsed this legislative proposal. Adoption of House Bill 2129 will move Kansas a step closer to achieving consistent coverage across all health plans. And this will make it easier for providers to offer effective treatment to increase utilization and quit rates. This legislation will improve the health of Kansans and yield economic benefits to the state. I want to thank you for your consideration. I'll be happy to address any questions at the appropriate time.
Thank you. Our next proponent, Kimber Richter. Dr. Richter, welcome to committee.
Thanks so much, Chairman Johnson and committee members, for giving me the opportunity to provide testimony in support of this bill. I'm Kim Richter. I'm professor of population health at the University of Kansas School of Medicine. I direct You Can Quit at the University of Kansas Hospital, which is a tobacco treatment program that serves over 2,000 patients per year. I'm also a member of the University of Kansas Cancer Center, and I'm providing this testimony on behalf of the Cancer Center and Roy Jensen, its director. As a National Cancer Institute, NCI, designated cancer center, the University of Kansas Cancer Center must demonstrate that we are significantly improving the health of Kansans and reducing the cancer burden in our region. One way that we can dramatically cut Kansans' chances of developing cancer is by helping them stop smoking. Tobacco use is the leading cause of preventable death and the top preventable cause of cancer in Kansas. 16.2% of all Kansas adults smoke, and that calculates out to about 350,000 Kansans. And tobacco use causes about 4,400 deaths from smoking-related illnesses per year in Kansas. There is very strong evidence that quitting smoking dramatically and quickly reduces risks for heart disease, stroke, and cancer. And that was reflected in Dr. Gurley's estimates. Quitting also improves overall quality of life and mental health. People who quit smoking gain on average 6 years of life, and that includes people who quit over the age of 65 and beyond. A recent study found that if smokers quit early, they can avoid 70% of their excess medical costs, as Mr. Kagan mentioned. Most smokers do try to quit, but most try to quit without any treatment because they can't afford it. This results in countless relapses, hopelessness, and decades of smoking before they're finally able to quit for good. The 2020 Surgeon General's report on smoking cessation concluded that FDA-approved smoking cessation medications and behavioral counseling are highly effective and cost-effective for quitting smoking, especially when they're used in combination. Medications and counseling help more people quit sooner. There's also strong evidence that when insurance plans cover cessation medications and counseling, it significantly reduces tobacco use, tobacco-related illnesses, and healthcare costs for enrollees. Based on this evidence and the data presented by Dr. Gurley, the expanded benefits included in this bill have very strong potential for significantly improving health, reducing cancer incidence, and reducing healthcare costs for Kansans. COVID hit smokers a lot harder than non-smokers. I just want to point out that with COVID, whether someone smokes or not can make the difference between being able to recover at home versus going into the hospital, or having a short stay in the hospital versus being treated on a ventilator in the ICU. The difference between recovering at home and ICU treatment can be, for a single case, hundreds of thousands of dollars and life or death. Even before the pandemic, providing comprehensive tobacco cessation benefits was effective, ethical, and financially smart. Under the current circumstances, it's critical. For these reasons, I urge you to support House Bill 2129.
For your testimony. Our next proponent, Sarah Prem, Tobacco Free Kansas Coalition. Welcome to committee.
Thank you, Chairman Johnson and committee members. I appreciate this opportunity. Again, my name is Sarah Prem, and I'm here today in my role as the president of the Tobacco Free Kansas Coalition. Tobacco Free Kansas, TFKC, supports HB 2129 because we believe that having this access to insurance coverage is important. Our coalition is made up of nearly 300 members representing public health, education, health coalitions, advocates, youth, parents, individuals, and all of us are working to advocate for laws and policies that will reduce tobacco use addiction, especially among children and high-risk populations. We believe that everyone should have access to comprehensive, barrier-free tobacco cessation benefits, such as what this bill will provide. Our stance is supported by, as Dr. Richter said, the Surgeon General's report that insurance coverage for smoking cessation that is comprehensive, barrier-free, and widely promoted increases the use of the treatment services. It leads to higher rates of successful quitting, and it's cost-effective. In short, it saves lives and it saves money. This bill provides enrollees in the state healthcare benefits program to access all 7 FDA-approved cessation medications and all 3 types of counseling. It permits the combination of pharmacotherapy and covers at least 4 90-day medication-supported tobacco cessation attempts per year. It also ensures there can be no lifetime limits, prior authorization, and cost sharing for all the benefits highlighted, and no annual limits on counseling. Quitting smoking is the single best thing a person can do for their health, and nearly 7 of 10 smokers want to quit. Quitting is also very difficult. We know that people who smoke may take 30 or more quit attempts on average before successfully quitting, and the provisions in this bill take that into account. It understands that quitting is difficult and the process is different for everyone. For all these reasons, the Tobacco Free Kansas Coalition supports the passage of HB 2129. Thank you so much for your time.
And thank you for your testimony. Thank you for the experience of all of the conferees so far. I don't have other proponents listed as oral proponents, but is there anyone else wishing to present as a proponent of House Bill 2129? I would direct the committee's attention to, I believe, 7 written proponents, and we do have their data as well, not to reduce that, but wanting to certainly recognize those wishing to speak yet. I do want to thank again the proponents in that half an hour ago I had given up ending close to on time, and you did a great job bringing us back on schedule, which I know is not easy, as passionate as you would be on the topic. So thank you for that. With that, committee questions? Representative Riley.
Thank you, Mr. Chair. Just wondering from any one of the proponents or opponents how you handle the switch over to vaping of the people that are not, quote, smoking, but now they're vaping, and if that is considered a win-win or just a win.
Go ahead, Kim.
I knew I was getting this one. So vaping is safer in some ways than combusted cigarettes because you're not inhaling carbon monoxide, and there's also a number of carcinogens that are not present in vaping in general that are present in cigarettes. On the other hand, we don't know the long-term effects of vaping or the effects on the heart disease or pulmonary disease. So I think in general, what what practitioners like my team do is encourage people to use the FDA-approved medications because we know what's in them and we know what's not in them. And but if someone wants to try vaping to quit smoking or to switch, then we encourage them to move forward and then check in with us to see how it's going. So the long run goal for vapors should be, until we know exactly what their safety is, that they should, stop, because we just don't, and it takes like 20, 30 years to know the health effects of cigarettes, and it could be true for vaping as well. But so I would say it's definitely making ground, maybe 6 yards out of 10.
Other questions, committee? Question that I would have deals with the change, trying to get a handle on going from the 2 90-day periods to the 4, and what that incremental piece is. If Chantix or some other, I don't know what treatments there are, is that something that I want to be on continuously? Are there risks to that? How does all of that play out?
I could speak to that as a tobacco treatment provider, or Rick, why don't you look like you were going to take a shot at it?
Go right ahead, Kim.
Yeah. So, the thing about smoking is that, and also the medications, is that what works well for one person does not work well for another person. And so before, people could only get one single pharmacotherapy for 2 rounds of treatment per year. And so they might try something and then find that it didn't work for them, or they had a rash with a patch, or they got, heartburn with gum. And then they would switch over to something else. And then all those false starts were counting against the amount of time they had to quit. So I think the intent behind this bill is to give people the opportunity to keep trying things until they find the thing that works for them, just like an antidepressant or blood pressure medication or asthma regimen, and then have enough time on it to be able to follow through on a full-length quit attempt. So for varenicline, for example, the course of treatment for Chantix is 3 months, but actually, if you take it for 6 months, you get even higher quit rates. So doctors in particular, and patients need the flexibility and the ability to try different things until they find a combination that works for them. Right now, it's like you got 2 shots and then you have to wait until the next year.
Thank you.
And actually, I was just going to add, Mr. Chairman, that from our assessment of the state employee health plan, they're now covering 3 quit attempts per year compared to the Affordable Care Act essential health benefit of 2, which is what you'll find in the private insurance market. And so it's not that much of a stretch for them to go from 3 to 4, but there are other provisions in the bill which would change some details in what the state employee health plan is offering. So, yeah.
Thank you. Other questions, committee? Yes. Representative Howe.
Thank you, Mr. Chairman. Thank you to the conferees here today. My question is in regards to non-medical cessation practices, whether it might be hypnosis or something like that. Is that included in this legislation? And could you touch on that? And also how this may apply to smokeless tobacco products?
Well, I mean, I might address part of that, and maybe Kim will be able to address another part. But I mean, this bill essentially just mirrors the benefit package that the legislature approved for CanCare in 2018. So it covers 3 forms of counseling, as Sarah Prem had indicated, and all of the FDA-approved medications. But these alternative therapies may or may not be effective, but they're not specifically mentioned in the CanCare benefit package, nor would I guess in for state employees. But Kim, I don't know what else we know about these alternative treatments.
Well, I think that anybody who were to would bill for these treatments would have to be a provider, a qualified provider for the most part, so or a tobacco treatment specialist, and so in general, a hypnosis only if a qualified provider would call it counseling and then give somebody hypnosis would it be covered, as far as I can tell. And they're not explicitly covered. I mean, what we tried to follow was evidence-based practice, and the Surgeon General's report of 2020 on smoking cessation specifically notes that hypnosis is not shown to be effective, although some people do find it helpful. It's just not something that has a strong evidence base. So in general, the intent of the bill is to not cover hypnosis or acupuncture because they don't have evidence for them.
Okay, thank you for that. And so just to clarify in my own mind, so this legislation would preclude those types of treatments to people seeking that?
I don't see anything in this legislation that would preclude it. It's just not specifically mentioned. I see Kim.
Right.
Yeah.
Yeah,
Thank you.
yeah, sorry. We can leave it at that.
I mean, I think that might be a question for the state employee health plan. If you go to your acupuncturist and try to get treated for tobacco addiction, you know, I don't know. That would be up to the state employee health plan as to whether they would cover that, but it's not part of this bill.
Are there any further questions? Seeing none, thank you again to our conferees for being with us today and taking your time. With that, I had asked if there were any other proponents. Are there any opponents wishing to appear on 2129? Is there anyone neutral? And anyone at all on 2129? Seeing none and hearing none, we will close the hearing. So thank you, committee. Thanks again to the conferees, and we are adjourned.